Hello and welcome to our new topic. Today's lecture focuses on substance abuse, a condition that sits at the intersection of pharmacology, neuroscience, psychiatry, internal medicine, and public health. Substance abuse is not merely a social issue or a moral weakness. It is a chronic, relapsing brain disorder involving maladaptive changes in reward circuits, stress systems, and executive control networks. As future clinicians, understanding both the pharmacology and neurobiology of these substances will allow you to recognize, manage, and counsel patients appropriately. So, let's start. The learning objectives are shown. Please take a look. By the end of this lecture, you should be able to clearly distinguish between substance abuse, dependence, and addiction. You should understand the neurobiology of reward pathways, classify major drugs of abuse mechanistically, recognize tolerance and withdrawal syndromes, and outline pharmacologic principles of management. These objectives are designed to move beyond memorization toward clinical reasoning. Addiction and dependence are often confused. Addiction refers to compulsive drug-seeking behavior despite harm. Dependence refers to physiological adaptation, resulting in withdrawal upon cessation. A patient may be dependent without being addicted, for example, long-term opioid therapy for pain. Conversely, cocaine produces intense addiction but relatively mild physical withdrawal. Substance abuse is the broader, modern term. It includes harmful use of any psychoactive substance. Addictive drugs share a common property. They activate the mesolimbic dopamine pathway, producing reinforcement and compulsion. This diagram illustrates how even a simple neuronal network contains feedback loops, presynaptic modulation, and crosstalk between neurotransmitter systems. When drugs interfere with one transmitter system, the overall effect becomes complex and unpredictable. This is why addiction is not explained by a single receptor, it is a network disorder. In other words, substance use disorder is a chronic relapsing brain disease involving neuroplastic changes. Dopamine in the ventral tegmental area and the nucleus accumbens of the mesolimbic system appears to play a primary role in the expression of reward, and excessive dopaminergic stimulation may lead to reinforcement such that the rewarded behavior may become compulsive, a common feature of addiction. Most addictive drugs enhance dopamine transmission in the mesolimbic pathway. Dopamine does not simply cause pleasure, it encodes salience and reinforcement learning. Repeated activation strengthens drug-associated cues and weakens inhibitory control. Thus, different drugs, different receptors, but the same final dopamine pathway. A unified model of addiction is shown with dopamine in the center. This slide categorizes drugs into depressants, stimulants, hallucinogens, dissociatives, and empathogens. Depressants reduce CNS activity. Stimulants increase monoamine transmission. Hallucinogens alter perception via 5-HT2A receptors. Dissociatives block NMDA receptors. And empathogens enhance serotonin-driven social bonding. This classification helps you predict both acute toxicity and withdrawal. In this lecture, we will talk about alcohols, hallucinogens, dissociative drugs and stimulants in that order. MDMA will be discussed together with amphetamines. The GABAergic drugs are discussed in separate lectures on sedatives, and opioids are discussed in a lecture on analgesics. Please see them to complete the discussion. Mechanism determines effect, toxicity, and addiction potential. The management of any substance abuse is similar in principles, and includes stabilization of acute episode, control of withdrawal syndrome, maintaining abstinence, psychosocial support and prevention of harm and long-term issues. Ethanol is hydrophilic and widely distributed. It remains one of the leading causes of preventable death globally. Social acceptance masks its pharmacological potency and systemic toxicity. Ethanol produces an apparent, excitatory, effect initially due to cortical disinhibition, followed by CNS depression. As levels rise, coordination declines, judgment becomes impaired, and respiratory centers are suppressed. Clinical effects correlate with blood concentration. At 50 to 100 mg per deciliter, mild sedation and slowed reaction occur. Above 300 mg per deciliter, coma develops. Above 500 mg per deciliter, respiratory failure is likely. Most countries do not allow blood alcohol level above 50 mg per deciliter or 0.05% for driving, although USA allows up to 80, and no wonder records a high incidence of drunk driving-related automobile accidents. Ethanol acts on multiple membrane proteins. Its effects are broad and nonspecific. It enhances GABA-A chloride currents and inhibits NMDA glutamate receptors. It has no single, ethanol receptor. Chronic use leads to tolerance, dependence, and withdrawal hyperexcitability. Wernicke-Korsakoff syndrome results from thiamine deficiency. Cardiomyopathy, endocrine dysfunction, carcinogenicity, and immunosuppression are long-term consequences. Ethanol is metabolized primarily by alcohol dehydrogenase to acetaldehyde, then by aldehyde dehydrogenase to acetate. Chronic use induces cytochrome P450 isoenzyme 2E1, increasing toxic metabolite production. Acetaldehyde accumulation produces flushing and nausea. Ethanol interacts through three mechanisms: additive CNS depression, enzyme induction, inhibition, and metabolic competition. Chronic use induces cytochrome P450 isoenzyme 2E1, which is able to generate a hepatotoxic metabolite of paracetamol, thus increasing hepatotoxicity risk with paracetamol. Acute use inhibits metabolism of some drugs. Management prioritizes airway protection, prevention of aspiration, glucose correction, and thiamine administration before glucose to prevent Wernicke's encephalopathy. Withdrawal prevention requires benzodiazepines. Electrolyte correction and cardiac monitoring are critical. Identification of alcohol use disorder allows structured intervention. Apart from psychosocial therapy, substituting the alcohol with a short course of a long-acting benzodiazepine is helpful to combat the withdrawal syndrome. Apart from that, additional drugs are used in alcohol use disorder, such as naltrexone blocks opioid-mediated reward pathways. Acamprosate stabilizes glutamate balance to help maintain abstinence. Disulfiram creates aversion by blocking aldehyde dehydrogenase that leads to alcohol-induced dysphoria and flushing. Topiramate and baclofen are used in selected cases. Management depends on whether alcohol use has stopped. If abstinent, maintain abstinence with acamprosate or naltrexone. If still drinking heavily, reduce intake and consider naltrexone or topiramate. Disulfiram requires motivation and supervision. Take time to carefully examine the algorithm and an associated mechanistic diagram shown here. In some regions, alcoholic beverages may be illegally distilled or poorly manufactured, or contaminated with methanol. Chronic alcohol users may unknowingly ingest methanol during binge drinking. The real issue is not methanol, but its metabolite, formic acid, causing metabolic acidosis and optic nerve damage. This metabolic conversion is carried out through alcohol dehydrogenase enzyme, and can be blocked by fomepizole. Formic acid is an optic nerve toxin. In severe cases, acute respiratory failure may take place. Hemodialysis is indicated in severe toxicity. Here is the summary. Ethylene glycol metabolizes to glycolic and oxalic acid, causing renal failure. No visual disturbance occurs. Management parallels methanol. Now, let's discuss other common substances of abuse. Marijuana or grass is extracted from hemp plants, while a more refined and potent form is hashish. The cannabinoids are a very promising group of drugs in a variety of conditions. Exogenous cannabinoids in marijuana act on CB1 receptors of endocannabinoids, modulating neurotransmitter release. Acute effects include euphoria and altered perception. High doses may cause psychosis. Medical uses include chemotherapy-induced nausea and chronic pain. LSD, psilocybin and mescaline are called psychedelics because they are able to produce hallucinations, especially visual. Despite the hallucinations, the user does not lose contact with surroundings and has self-awareness. These substances activate 5-HT2A receptors and do not act on dopamine pathways, hence generally do not cause dependence. Tachyphylaxis develops rapidly. In contrast, PCP and ketamine produce hallucinations as well as loss of self-awareness. Hence they are dissociative hallucinogens. They can induce frank psychosis and hypertension. Addiction potential is lower than stimulants, which are our next group of substances. Nicotine is a CNS stimulant that activates nicotinic receptors of acetylcholine, increasing dopamine release. It also stimulates autonomic ganglia and hence produce multi-system effects attributable to sympathetic and parasympathetic stimulation at the same time. The dominant effect depends on the organ system involved. Withdrawal causes irritability and craving. Chronic use leads to cardiovascular and pulmonary disease, and it remains as a leading cause of preventable death globally. Amphetamines are indirect-acting sympathomimetics because these do not act on sympathetic receptors directly but rather increase monoamine release and also block their reuptake. Dopamine-related activity makes it addictive. One related compound is MDMA or ecstasy, that preferentially increases serotonergic activity and hence helps develop social bonding among participants of rave parties, where it is widely used. Acute toxicity includes many symptoms of sympathetic overactivity. Acute toxicity of MDMA includes hyperthermia and psychosis. Chronic use causes neurotoxicity and severe depression, especially in case of MDMA due to serotonin depletion. Cocaine has many effects similar to amphetamines but has a higher addictive potential. It blocks monoamine reuptake in peripheral nerve sodium channels. Acute toxicity includes arrhythmias and seizures. Withdrawal presents with depression and fatigue. The most commonly used psychoactive substance is caffeine, present in coffee, tea, chocolates and also in certain other beverages. It blocks adenosine receptors, increasing alertness. In addition, it releases monoamines from neurons and also acts as a phosphodiesterase inhibitor. It has low addiction potential but causes withdrawal headaches. This slide and the next is a good and comprehensive review tables because they integrate color-coded drug class, receptor target, acute toxicity, management, social impact, withdrawal, and chronic complications. They help synthesize mechanistic knowledge into clinical application. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!